afternoon to everyone, and thank you for connecting with us today in our fourth section of the Brownback Lunch series presentation. My name is Elizabeth Vale. I am the Communication Manager of the Puerto Rico Public Health Trust, which is a program of the Puerto Rico Science, which is a program of the Puerto Rico Science, Technology, and Research Trust. Our mission is to work against the health inequity in the communities of Puerto Rico. First, I would like to make several requests and announcements during the presentation. I would like to inform you that this event will be conducted only in English. Please set your microphones in mute while you are listening, and please turn off your video to avoid distraction and achieve a better connection. This presentation will be recorded for your convenience. The link will be shared with all the participants and will be available in the Puerto Rico Public Health YouTube channel for your reference. There will be a Q&A section at the end of the conference, but feel free to use the chat to introduce yourself, write your questions, and make your comments. As part of the World Immunization Week, which is held from today through April 30, we'll be holding this presentation with the topic Rethinking the Future of Immunization in the Post-COVID Era. Before we start, I would like to introduce my guest. With us is Vanessa Lugo Flores. Vanessa is a scientist, attorney, an entrepreneur with over 15 years of experience in the health industry throughout Puerto Rico and Latin America. She has a special emphasis in immunization, virology, and oncology. As principal of customer solution at FARO, her work focuses on the intersection of data, policy, and commercialization of health solutions. With us is also our special guest, which is Gregg Gondalves. I'm so happy to have Gregg with us. Gregg is an associate professor of law at Yale Law School, the co-director of the Global Health Justice Partnership, a leading HIV/AIDS activist. Gonsalves is also an assistant professor of epidemiology of microbial diseases at Yale School of Public Health. His research focuses on the use of quantitative models for improving the response to epidemic disease. Now, with all of you, is Vanessa Lugo, who will be presenting and moderating this event. Vanessa, thank you, and to you and Gregg for being with us today. Please go ahead.
Thank you, Elizabeth, and thank you, Gregg, and all that have joined the call today. We are going to reimagine today together the future of immunization. And that future we want to see is a future with higher vaccination rates, because we are able to design human-centric and data-enabled solutions. Those are the topics that we will elaborate on. Please join the conversation, send your questions. Health is a critical productivity asset for any country. And maybe we're not used to think of health in these terms, but the pandemic has made evident that ensuring the health of individuals, of communities, is indispensable for a country to work. And by that, I mean to provide life and provide livelihood for all. And now that we truly understand how severe the individual, societal, economic impacts of an outbreak can be, we can and we should prevent and be proactive in preventing future outbreaks. So if we want to keep our country safe and productive, we need to keep them healthy. Biggest learning of this pandemic. If we want to keep them healthy, we need to focus our efforts on prevention. And in terms of prevention, immunization against infectious disease is one of the most effective tools to ensure public health. So in the post-COVID era, immunization should play a central role in preventing future outbreaks, not only of COVID-19, but of other infectious diseases. However, in our reality in Puerto Rico, immunization has traditionally been just part of the checklist that we use when we enroll our kids in school. It's not actually seen and consciously accepted as a proactive act to prevent disease for oneself or to prevent disease in the community. And I'll illustrate this point. If we look at the vaccination rates of school-age kids, and we look specifically at the vaccines that are included, that are mandatory in our school vaccination schedule, we'll find vaccination rates actually over 90%. School-age kids in Puerto Rico are indeed protected against those diseases. But when we look outside of that range of age and we look into, for example, infants, children before they reach school, actually before they even reach preschool, and we look at vaccination rates of measles, for example, we find vaccination rates hovering between 45, 55%. That's nowhere near the levels we would need for herd immunity. And the same is true if we look at the other side of the spectrum in terms of age. And when we look at adults, for example, flu vaccination, we will never see numbers over 20, 25%. Some years we've actually seen numbers as low as 15%. So it's clearly in Puerto Rico, we're looking at immunization as something that's for kids, that's actually for school-age kids. And we are not necessarily being effective as a country, as an ecosystem, in furthering protection of the community from infectious disease. So clearly, we need to think about immunization differently, and we need to act upon immunization differently. So our first question to Gregg, you've been working on multiple fronts related to COVID-19. One of them is the COVID-19 Research Working Group. This is a group that focuses on epidemiology, modeling, community, and global health. Based on your experience, how can we anticipate immunization in general to change in the post-COVID era?
Can you hear me now?
Yes.
So, I mean, first of all, we have to think about what it's going to happen in the COVID era, because in the Ebola epidemic in West Africa, routine childhood immunizations for measles, pertussis went down considerably, and it depended on the province that was the province. The provinces that were more affected by Ebola had lower immunization rates, and so on and so on. And so there's some recovery afterwards, but you know, the question is that we're all being asked to social distance right now, and people are on routine immunization schedules. And the question is, has anybody in Puerto Rico seen any sort of disruptions in sort of required immunizations for children in the context of the current outbreak? I think the other thing to think about is that we're liable to see a return of coronavirus this fall. And so, although it's not in the context of routine childhood immunization, flu vaccines are generally, seasonal flu vaccines have pretty low uptake across the US. And I'm not quite sure what the uptake is in Puerto Rico, but if we have a flu and coronavirus season this year, it's going to be doubly important to ensure that people get vaccinated for seasonal influenza as well, to both protect them against getting both diseases in succession at the same time, but also to rule out influenza early on, because they have overlapping symptoms that can delay a diagnosis. And so it's hard to predict what's going to happen in the aftermath of the epidemic. The question would be to see right now, just from immunization sites on the island, like how this is impacting mothers and parents coming for well child visits, and to think about the disruptions now, and what do they look like? Are they the same across the island? Are they the same among different demographic groups? Do people who have the resources to social distance still figure out a way to get their immunizations, while people are having trouble trying to make ends meet and trying to navigate the past few weeks of social isolation, having trouble dealing with accessing healthcare because there's too many things on their plate at the current moment?
Yeah, and I'll answer a few of the questions that you posed. The first one, the rates of flu immunization in Puerto Rico, they are indeed low. Across age groups, we have different numbers for different age groups, but when we look at it as a whole, it doesn't go above 15 to 20%. So indeed, they are very low. And it's something that we've seen year over year. So this is not a new, we shouldn't say it's a new phenomena due to either COVID or the recent hurricanes. It's consistent. And in terms of whether we've seen disruption in the current vaccines, the answer is a resounding yes. Huge disruption. Actually, the disruption started very early in the year because we had a series of earthquakes at the end of 2019 and the beginning of 2020. And we saw an impact not only in the geography where we had the most direct impact from the earthquakes, but actually island-wide. And I know, because I recognize the name, I know we have a few providers on the call. I know we have a few manufacturers on the call as well. And it'd be very interesting at the end of the conversation to hear the experience. And we'll move shortly to explore the gaps between the demand side and the supply side of vaccines. But before we do that, I want to return to the experience in terms of having an outbreak or an epidemic, and how people react to that during or after that epidemic is over. Could you share some experiences of other outbreaks in the past? Do they move people to reconsider vaccines, or to be more receptive to using vaccines for that particular disease or for others? For example, should we anticipate that this experience with COVID-19 will make people more receptive to the flu vaccine the next season?
So vaccine, I'm not an expert on immunization and vaccine hesitancy, but I think you have to think about if we're talking about Puerto Rico, we have to talk about the earthquakes, we have to talk about Hurricane Maria, we have to talk about the sort of, if you want to go back even further, we can talk about the austerity measures and the withdrawal of tax-free status for corporations in Puerto Rico. There's a lot of stuff that sort of has weakened Puerto Rico's healthcare infrastructure. And I'd be less inclined to say it's individual factors that are going to affect vaccination in the post-COVID environment than what support Puerto Rico gets from the federal government and other actors to sort of catch up on these vaccinations that might have been missed over the past several weeks, or I don't know how long this is going to go on, but it could be 6 months where a whole sort of set of young infants miss their early vaccinations, and that's going to take resources, time and effort, supplies that are above and beyond the immunizations themselves. There may be PPE, personal protective equipment, that's going to be necessary, so nurses and immunization officers can go out and do house calls. And so I don't think it's about how people are going to feel about vaccinations per se. We know there's sort of vaccine hesitancy and pockets of it all over the country. And so I'm not quite sure sort of what kind of vaccine hesitancy is in Puerto Rico, but I'm in the Northeast in the US, and we have communities that have measles outbreaks in Brooklyn, New York, and in Rockland, in other communities that have terrible vaccine coverage for children for diseases that are entirely preventable, like measles. So my sense is that it's the infrastructure and the resources that are going to depend on whether everybody can catch up in Puerto Rico and then get prepared for sort of what's going to come next November, December, January.
Great. So let me speak a little bit about the particularities of Puerto Rico, because you're talking about a particular challenge that we face in our market, and it's that in terms of infrastructure, and it's that the supply side and the demand side are not necessarily aligned. And by the demand side, I mean the individual who is a candidate for immunization or who makes the immunization decisions for others. So it could be an adult who is defining whether he should vaccinate himself, or it could be a mother that is seeking immunization services for her children. And by the supply side, I mean those who provide the immunization services. So it could be a vaccination center or an immunizing pharmacy. And the government and manufacturers are also on this supply side. Now, when the demand side and the supply side are misaligned, immunization does not happen, at least not to the levels that we would like, or to the levels that would provide us with herd immunities. So that misalignment creates a gap in basically the person who needs to be protected by the vaccine does not get to connect with the supplier of the vaccine. And in Puerto Rico in particular, some of the challenges that are fueling this gap are well known to the people that are here in the call. For example, you touched upon vaccine hesitancy. It is not necessarily an emergency, but it is real and it is urgent that it be addressed. We also lack consistent education around prevention and vaccines that is culturally relevant. Another obstacle that we see is limited provider participation due to economic issues. Vaccination is not necessarily a profitable proposition for providers. We also see suboptimal inventory levels. So for some vaccines, we struggle because we have such a limited inventory that we can only reach a small portion of the population. And yet for others, the problem is a surplus, and vaccines expire on use. So, and there's another challenge that is around access. We have, in general terms, very good access to vaccines in Puerto Rico, but there are still some pockets of the population, for example, certain Medicaid adults, that lack coverage to all of the recommended vaccines. But of course, we're not here to focus on the problems. We're here to focus on the solutions. And the solutions to these challenges will require us to truly understand the humans involved. So the infrastructure around that human makes sense and is guided in the right direction. So we need to understand their beliefs, their needs, the incentives that shape their behavior, their full experience as they interact with the healthcare system. We need to understand and actually map the patient immunization journey in order to design effective solutions. So another question for you, Gregg. You've been working for 30 years with HIV/AIDS and with other global health issues. What learnings can you share that can help us bridge that gap between those who need a service, in this case, vaccination, and those who provide the service? How important is human centricity in bridging this gap?
Okay, so now you're talking about something that I have very strong feelings and experience with, because, you know, I'm HIV positive. I take antiretroviral therapy. And as we started to do work around the world on antiretroviral therapy, we realized having drugs is only one step in getting people to take them. And one of the key sort of lessons of the AIDS epidemic is you need community-based treatment literacy and advocacy. And it's very interesting because there's a friend of mine named Moises Agosto, who was with the National Minority AIDS Council for a long time, then moved back to Puerto Rico, and now he's back in Washington, D.C. But Moises pioneered this many, many years ago for NMAC and its partner organizations. And the idea is that, you know, we need to be able to, as communities, have a better understanding of our health risks and what puts us in danger of developing disease, but also understand what, in the context of HIV, what the drugs were about, what the side effects were, even things as seemingly complicated as how does your immune system work and how does the HIV virus work? And so, you know, Moises and others of us, and now around the world, have built up community education programs that are talking to people one-on-one. And you know, I've worked I worked before I came back to the US. I was living in South Africa, and we did a lot of work in rural communities around the region, in Lesotho and Botswana and others, where people maybe had a primary education. But with a couple of training sessions, they could begin to understand what HIV was, how it worked, the immune system, what all the drugs for the disease did, and became advocates for getting those drugs into their communities, because the information was power to them. They understood that in countries with 30% prevalence of HIV, that understanding what these drugs were for and how they could save their families' lives was important to them. I think it's the same thing in the context of health across the US. One of the interesting, my friend Amy Kaczynski and I, she's at the law school, we just sent in a piece that we were hoping to get published by a place called the Boston Review. And we said in the age of COVID, what we need is a new emphasis on community health workers. And mostly because we're going to have to do tons of contact tracing and testing and isolation in the context of this epidemic. But guess what? You know, there are millions of people unemployed now who could use jobs. And community health workers come from the communities they serve, right? They understand the lives of the people around them because they're their neighbors. And what we're suggesting is that the federal government should invest in a rapid expansion of community health workers, not just for now, but for after it's all over. So what can they do? They can immunize. They can do community education about immunization. They can talk about breast cancer screening. They can talk about diabetes screening. And the idea is that these don't have to be physicians or nurses or people with specialized training. They can be trained like we did in HIV to understand the science, to understand the details, to be able to refer people to care, to help understand what the obstacles are. You know, suppose I'm a single dad with a child and I can't get to the clinic, you know, 9 to 5. They can interface with you, not just on health issues, but on the issues that sort of mediate access to healthcare as well. So I think the COVID epidemic might be an opportunity to get the US. We have a very fragmented healthcare system, right? It's a patchwork. There are millions of people who are uninsured or underinsured. There are people at the margins of our healthcare system that are outside of our circle of care. And that's not just about COVID-19. It's about immunization. It's about cancer. It's about diabetes. It's about obesity. It's about all the things we care about. We know what health disparities have done to the US, what they've done to communities of color, to Latino communities, to African-American communities, to indigenous communities. And so the way we're thinking about the sort of expansion of the community health worker programs is to address what's broken in the American healthcare system, to deal with all the health issues we face, from immunization for children all the way up to thinking about immunization for people who are my age and older, who are now being recommended to get shingles vaccines and adult immunizations. So yeah.
So when we speak about the human experience and human centricity, if I'm trying to paraphrase and summarize what you've shared, is we should be talking about the individual and community level. So these are efforts that we need to undertake that are as close to that person, to that individual as possible, And who better, and the people that do that are not the ones sitting in a boardroom, are not the ones sitting at the hospital ward. I mean, they can certainly contribute, but then the ones who will be most effective are the peers, are the neighbors, are the members of their faith community, for example. So this is an effort that if we were to invest in it, it would have a very high return, because it's not only about one issue. It's not about immunization. It can be about immunization and COVID and cancer and HIV and the many other maladies that impact our communities, because each individual will have a few of them, not just one. And then we need to provide something that is of value to that and relevant to that individual, not just the provider of the service, but the recipient of the service.
Yeah, and the other thing is we have to change our values a bit. You know, specialty care. So even in New Haven, where I live, the hospital makes great investments in very expensive specialty care, but primary care is not well thought of, and the idea of community health care and community health workers is undervalued. It's pretty clear that we don't have enough resources in the U.S. in many places that are underserved by doctors and nurses to get us where we need to go. And so I think we need to see a new respect and a new valuing of community health workers, community health educators, to take us into the next step, so that we create a new politics of care in the United States, and which is from the ground up, and it's not from the teaching hospitals and these fancy clinics that are doing these high-tech surgeries or high-tech interventions, but are doing the basic sort of community healthcare that really is going to determine what our health is over the course of our life.
And I hear, and you confirm if I'm hearing right, an invitation or a call to action to the suppliers of care to shift, I'm not saying completely, but include in their investment and in their priorities, in their focus, these concepts around community level services. Certainly we do need to invest. And for example, if I were a manufacturer of a vaccine, or if I were an immunizing pharmacist, certainly we need to continue to invest in things we're investing now, but we also need to integrate into the planning and the investment these other players that not necessarily exist. The experience in Puerto Rico is not very different from the experience in New Haven in terms of the level of community workers available and trained. So we need to get these people on board in terms of care, and for that we'll need investment and think about new ways of investing resources from the supply side so that it works on the demand side.
Yeah, it's the foundation of everything, right? All the specialty care is like the fancy stuff on the roof that, you know, that's, if your foundation isn't firm, it's not going to work. The interesting thing is that I think Michael Bennett and Elizabeth Warren just put in a community health core bill in around COVID-19 to expand. So we have 120,000 community health workers in the US right now, roughly speaking. We need 3, 4, 5 times of that. And I think they put in a bill to sort of fund those kinds of positions. Again, my preference would be to say that it's not a short-term thing, that we use these new workers to stay in communities, to continue to keep protecting their health, because, you know, none of us had an idea that this pandemic was coming, and we don't know what's going to come next. We also have this looming health catastrophe weighing over us, which is the climate crisis. And island nations and island states and territories are going to have a huge issue with this sort of the health impacts of climate change and the way it's going to reshape our health. And community health workers can be part of helping to prepare communities to face the new challenge, whether they're infectious or chronic diseases or other kinds of health effects you're going to have from sort of climate change as it sweeps over us in the next 20, 30 years.
And let me talk about a different subject. It's still related, but it's different. I'm going to pivot a bit towards data. We've talked about the human community component of solutions to our challenges. I want to talk now about the data component to our challenges. So if we want to design effective solutions to bridge that gap between those who need the vaccine and those who supply the vaccines, we also need to be guided by data, not just opinions or the tradition of how we're used to do things. And this data need to generate intelligence, and I'll illustrate with a few examples. Do we really understand why seniors will not get a flu shot? Even if it's free, the providers and the insurers invest heavily on education, and they offer convenient alternatives to administer the vaccine. They go to where the people gather. Some of them even provide rewards, and still seniors will not accept the vaccine. We're actually seeing vaccination rates around 15% for people over 65. And if the question is, do we really understand why? And the answer is no, we really don't know. I mean, we could theorize. I'm sure we all have theories around it, but unless we generate the data and we dig into it, we really don't know for sure. I'll provide another example. Have we quantified the clinical and economic impact of an incomplete dose of childhood vaccines? For example, pneumonia that has 4 doses, and not always those 4 doses are administered at the right time. The answer again is no. We really don't know what is the true impact in Puerto Rico. We may extrapolate using data from other jurisdictions, but we don't really have our local understanding, and it's a challenge for all of us, for the island state, you know. And because if we really don't understand the root causes of the problems we're trying to solve, then it's very difficult to generate effective solutions. Now I'm aware of what I'm proposing is a significant undertaking, because it's not only about collecting relevant data, it's about aggregating the data, curating it, analyzing it, generating wisdom from it, but most importantly, socializing it in a way that resonates with the particular audience that you're trying to influence. So I know your research focuses on quantitative models to improve the response to epidemic diseases. I know your work is data-driven for a researcher, but even more so because it revolves around quantitative models. What insights should be considered when we try to develop data-enabled solutions? In this case, immunization, but also in general. And how important is it to generate local intelligence and then to socialize it?
So there are 2 people I work with here at Yale. Saad Ulmer, who used to be at Emory, but Emory's Vaccine Center, and now he's the head of our Global Health Institute. He's done a lot of work on vaccine hesitancy and vaccination rates across the world. And so he's done a lot of quantitative research on why people do and don't accept vaccination. My colleague Dan Weinberger has talked about the difference in vaccination schedules for pneumococcal disease, for instance, and whether changing the vaccination schedule to drop a dose would be as effective as the current sort of recommended dosing. So I think there's a lot of that kind of work going on. The work you just talked about, though, about like understanding what why a 65-year-old grandmother does not want to get a vaccine needs a different kind of work that's qualitative research that, you know, we're talking about the differences in what gets valued in sort of medical care, and what gets valued sometimes in public health research is the quantitative stuff that I do, but I think you need anthropologists, sociologists, psychologists, and others to do some of this work around vaccine uptake. And there are people who do it, but it's really intensive field work to understand what are the barriers in communities at the individual level, so whether I want to get vaccinated or not, in the community level, and going up the chain. And so I'm not a super consumer of that literature, but my sense is that just knowing the composition of the faculty at my own School of Public Health is that we don't have a lot of anthropologists and sociologists among us who could do that work that you're talking about to understand what the individual level determinants are, the community level determinants are of whether people get vaccines, that you can't just get from a survey instrument or looking at quantitative data. And so, you know, I'm going to ask around and see what else I can find from Saad and from Dan, because they think a lot about these issues. They'd be actually great people to talk about immunization on any other call, because they're, you know, Saad has devoted his life to vaccination and immunization, and although it's now deeply embedded in the COVID response here in Connecticut.
So again, that understanding of the human behind it, and that, again, the topic about going to the field, really understanding your community, really getting close to people to understand what's going on and then be able to react effectively through it. That topic is, that undercurrent is flowing through this angle as well.
Yeah, the other thing about immunization to me is that if we start to break it down, like childhood immunization, there are school requirements, right, to go to school to have certain vaccines. There are optional vaccines in some places, for instance, HPV vaccine for prepubescent teenagers. There's the adult vaccines like shingles and stuff like that are recommended. And then there's seasonal vaccines that all have different sort of kinds of incentives built into their uptake, motivations for people to take it, cultural resistance. You know, HPV is vaccine has been resisted because people think it sort of encourages teenage sexual behavior. There's lots of stuff that are very specific to the kinds of vaccinations we're talking about in different life stages, which are going to require different solutions. I do think this is all can be addressed by understanding your communities better, doing the work to get people vaccinated and understand their health at the community level. It's not something that can happen from the top down.
Great. So I'm going to summarize a bit the themes that have come up. So during this talk to reimagine immunization, and Gregg, you made an important point. It's not only about the distant future, but about the present as well. So I'm going to change the middle way. I'm going to change the title of this talk to reimagine the present and the future of immunization. We've discussed a few themes. First, the importance of the person, the human that we are trying to protect, and the importance of interacting and understanding that human at his or her level and terms, and going to the field, the importance of community interventions. We've also talked about the need to increase our capacity to do that with community health workers and other actors that we don't necessarily have right now, or don't have to the level that we need in terms of numbers and of trainings. And therefore that's an area that we should be concentrating on, thinking about it, investing in it. We've also talked about the need for not only quantitative data, but qualitative data, and also about the need to look at each disease and each age cohort differently. So we can't think about one size fits all solutions, but we need to look closely at adolescents for HPV versus seniors for flu versus young children for pneumonia, and the list goes on. So it's detailed, it's field work, it's piece by piece investment of time and resources and energy to ensure that we get it right. And finally, this was one of your earlier points, that we also need to make sure that the infrastructure is in place to be able to do this. So it's not only about the individual or the direct supplier of the service, but also of the infrastructure of Puerto Rico as a whole that enables that connection between the person needing the service and the service provider to actually happen, and to happen in an effective fashion. So your work, Gregg, in true Yale form, touches upon different angles. And in your particular case, it's law, it's policy, epidemiology, social justice. So with that a very rounded view, any final thoughts you want to share with us in terms of a reimagined present and future of immunization?
I mean, the only thing I'd say is the COVID-19 epidemic is scary. But many people die of preventable, immunizable diseases every year. People die of the flu. We can do something about all of them. And so this might be an opportunity to get everybody's focused on public health now. It's never important.
Yeah.
Public health is a thing that if it works, you don't see its benefits, right? And so let's use this opportunity while everybody's thinking about public health to build on it for a healthier Puerto Rico and a healthier Connecticut.
Thank you. I want to thank you, Gregg, for your generosity of time and insights. I want to thank the Puerto Rico Public Trust for inviting us to participate in this Brown Bag Launch Series. And I also want to thank all of you who joined from your homes. Let's get participatory and open the line for questions. Elizabeth, are there any questions from the audience?
Yes, thank you. And please, feel free to make that question to the expert. In the meantime, I'm going to say that we are going to pull in a evaluation of this activity, help us make things better and know a little bit more about our audience. So I really appreciate you make this presentation. But in the meantime, Vanessa, is a question from Necha Martinez, who said, what do you think we should do, or how we can encourage people to get vaccinated?
That can be a very simple or a very complicated question. And I'll take the complicated route for it. I always do. It's so important to be able to prevent infectious disease, and for people like me who are advocates for vaccination, it seems so clear. The benefits seem so clear, like a no-brainer, that sometimes it's hard for us to understand why other people don't see it. But there's a lot to be done. And again, there is a gap. The gap is real. There are people who believe in vaccines and want to provide the vaccination services. There are many people who either are not interested or reject vaccines, and others that actually want them, but still they can't get them for many challenges and because of many challenges. And we discussed a few of them today. I think the solutions that during this discussion have come up, and to answer your question more directly, is that we need to understand that what that human needs and what that human wants, and how better to communicate with that person at his or her level and terms, not necessarily through a program within a hospital, maybe not even within a vaccination center, but at the community level. Maybe it is the school, maybe it is the church, maybe it is the community center in their neighborhood. But we really need to connect with humans and understand what they think and what they feel, and be able to provide the information and the services in a way that make them relevant and that make them attractive for that person. So in order to do that, that may sound simple, but in order to do that, there's a lot of investment, and I don't mean money, certainly that will be necessary, but I mean in terms of thought, in terms of time, in terms of getting the right people to collaborate to generate those solutions. And this is a point that I think we've made, but we need to make more directly. No one can do this alone. So no vaccination center, no immunizing pharmacy, no government agency, no vaccine manufacturer will be able to come up with a solution unless we all work together.
Yeah, one other thing to mention is that my colleague Dan Kahanas at the law school here talks about the role of cultural cognition in vaccine hesitancy, and that whether you're a rich community in the islands off of Seattle or a Hasidic community in Brooklyn, New York, a lot of resistance to vaccines is based not on the science and the health literacy we gave, is that your group has some suspicion around vaccines or climate change or whatever, and your membership of that group is more important to you than the health effects of the vaccine itself. And we see this with the people going out and protesting without the masks in Georgia and Tennessee and elsewhere around the US. I'm sure they're aware that COVID-19 is deadly, but there's a strong cultural and tribal political view that they need to sort of put themselves at risk, even though they probably know the facts if you ask them to that outside of the context of those demonstrations. So vaccines or hesitancy is not just about the obvious sort of health information we have to get to people and dealing with the barriers. There are deep sort of cultural issues that we need to confront too, particularly in communities that have wholesale resistance to vaccines.
Any other questions?
Sorry, hello, do you hear me now?
Yep.
Other thing that I would like to, and maybe this is my question, and it's a curious that I have. How long you as an expert in this team, how long you think it would get to have a vaccine for the COVID-19? And also, once we have it, how long it would take to get to the people? Because I think it's gonna last at least 2 years. You know, not for the vaccine, but the epidemic. So I really want to know your thoughts on that.
So I'm old enough to remember when Margaret Heckler, who was President Reagan's Secretary of Health and Human Services, said in 1984 that we'd have a vaccine for HIV in 2 years. We still don't have one. And so the idea that we're going to have a COVID vaccine in a year to 18 months is wildly optimistic, right? You know, maybe if everything goes well, trials go well, maybe in 4 years or so. But also remember that, as you said, the access issues are going to be critical. Mm-hmm. We're probably going to want to vaccinate healthcare workers first, then first responders. And we know this from health interventions in general, that there are disparities in access, right? And while we're triaging who gets the vaccines, it's also going to be some, you know, you see people who can find ways to get these N95 respirators walking around New York City or other places. People are going to buy access to the vaccines because they have connections and can do so. So once we have a vaccine, I think the whole idea is that we have to make sure that it gets to everybody who needs it all across the country in a way that doesn't sort of depend on who you are, what you look like, how much money you make, what state you live in, what territory you live in. So, yeah.
And also think about the scale of this endeavor. Let's think for a moment that our target, and I'm just making this up for illustration purposes, let's think that our target is to vaccinate against COVID only a third of the population of Puerto Rico. That's 1 million people. How do you ship, pack, distribute, handle 1 million vials? So the scale of it also needs to be considered. But even though it will take time, to get this vaccine, it wouldn't be wasteful for us to start thinking about what would we need to put in place. So we are ready to supply this vaccine when indeed it becomes available.
Yeah, if you can't get the vaccine, go ahead.
I'm sorry, I have a question for Gregg. This question is from Eduardo Cetina, and he asked that, okay, any jurisdiction where there is an individual-based incentive for adults to get vaccinated.
Huh.
If you know of any jurisdiction where there is an individual-based incentive for adults to get vaccinated.
I bet there are. I don't know, but if Eduardo emails me, I will find out the information, and I'm going to put my email in the chat so that Eduardo, I'll find out and I'll get back to you.
Thank you. I make the okay. Thank you. I will. Vanessa, if you can also put your contact there so the people can reach you after we finish here. The last thing that I just want to mention, this is a comment from Francisco Javier Jimenez, and he say, if I didn't misunderstood the information, it was mentioned that kids immunization rates are between 50 and 55%. Is that correct, or refer to a specific vaccine?
No, that I was referring to a specific vaccine. When we look at, for example, infants, those are children that are around 3 or younger, and we look at measles in particular, we see vaccination rates around 50%. But if we look at school-age kids, once kids get to school, and we look at the school-required vaccines, we're actually over 90% for most of them. So the vaccination rates are superb for almost all vaccines in school-age kids. And it's also actually something we should be very, very proud of as a jurisdiction.
Okay. So any other question that anyone have? This is the moment. Here are the experts, and we are, as we mentioned in the beginning of this conversation, that today is the beginning of the World Vaccination Week. So we are very aligned to, this topic is very aligned of what's happening globally. Any other question?
People are actually writing the questions.
Excuse me?
I see some in the chat.
Okay, I think if you want to say it aloud, it will be great.
Vanessa, you want to pick one out of there? I'm scrolling through.
Sure, there's one about the vaccination rate for flu. If we look at BRFSS over the last, I'd say 5 to 6 years, we'll see it hover around 18, 22, 25. If we look at other sources that are not official, but that could give us some direction in terms of the numbers, we see in the Head Start centers, when you have direct interventions with Head Start age kids, they could be around 25% the vaccination rate for flu, if you have direct education and immunization interventions. I know VOCES has a project for that, and that's where I'm getting the numbers from. But if you look at that same age group, if you don't do direct intervention, then the numbers for last season were actually 5.2%, extremely low. Extremely low. If you look at some data from health insurance companies, and this is anecdotal data that they've shared, they see it between the 20 and 25. That resonates with what we see in the BRFSS. So it ranges from cohort to cohort but we don't have very detailed data around that. That's an opportunity that we have to strengthen that information.
Okay, I have a question for Gregg here. We said, this is from Eduardo Satina, and he said, Gregg, do you know of any state that has a unified vaccination registry like what Luis mentions above?
So registry of people who've been vaccinated, or?
Maybe it's like a unified vaccination registration, something like that. Yes, that's what he said. Mm-hmm.
I do not know, but Eduardo has the other question about the incentives, so I'm going to find out that one too.
You have homework, Gregg. You have homework.
I know. I do my homework.
I can provide some context. There are immunization registries around the U.S., including Puerto Rico, that actually began as procurement tools by the CDC and the BFC program. So initially, the registries were actually procurement databases, and with time, because of population health management and a recognition of the need to have this centralized registry, the CDC has been moving the vaccination programs throughout the states, including Puerto Rico, to make their registries more robust. And there's been investment in terms of time and funds from the CDC for that. But of course, it's a process. I mean, we can't expect any jurisdiction, including Puerto Rico, to transition from a procurement tool to a population management tool overnight. So I know there's been great progress made in Puerto Rico, but we still, of course, have some way to go.
We are already in the time. Victor wants to make a point, so our host will be unmute him. Victor, you are there? Go ahead. Are you hear me, Victor?
He's still on mute.
Yes. You hear me?
Okay, now. Yes.
Yes, my question is my question related to what do you think if people mindset is going to change after the COVID pandemic in terms of accept more vaccines as part of a preventive services? Do you believe that people are going to change their mind in terms of accept vaccines after that? That's my question.
So I think this COVID-19 is something we've never seen before. It's, it's one of the most devastating. I don't think there's anything in my generation that compares to it. I think it's the most big historical event we've seen in a long time in public health since the 1918 flu. So I think things are going to be completely different once this is all over. It's like World War I, World War II, the flu pandemic. We've never seen such a big event that brings the United States to its knees, has unemployment greater than the Great Depression. What we are on the other side, what we're going to look like, what we're going to do is up to us. And I think we've been talking about building up community health work and all this sort of health promotion as an opportunity with COVID-19. And I think, I don't know if people will be more interested in taking up vaccines after COVID-19, but we can make that happen. And so I think that's been a little bit of the thrust of this call, is that there are things we can do now. We can take advantage of the interest and the focus on public health to say, we're going to get you ready for a COVID-19 vaccine. How we're going to do that? We're going to immunize children, teenagers, adults, and seniors for the diseases we can now prevent. So when a COVID-19 vaccine comes along, we'll be ready to do that too.
And I'll echo your comments, Gregg. It's not about sitting and watching what will happen, but actually being proactive and making it happen, and ensuring that the human-centric component is there, and ensuring that we're guided by evidence and by data. So to the extent that we are proactive in designing solutions that are human-centric, that are community-based, and that are data-enabled, we'll be in a good position. to steer things into prevention and protecting our communities.
I just want to make a comment. Do you hear me? I am on mute. Do you hear me?
Yes.
We are in the time. This is from 12 to 1, and we want to respect that. We have many comments in the chat in order to get back to the people who join us this afternoon. I make a promise that I will capture all that questions, comments, and also put together. We have your emails from all of you because you registered first. So we have the opportunity to get back to you with all this information. And I promise with Gregg and also Vanessa that we are going to put this together in order to send to you all the Q&As and comments that were developed in this chat. It was a great information. The vaccine is the flavor of the month and will be for the next years. COVID put this on the map again because it was the people resist to do so. So as somebody mentioned, this going to change the mentality of many people that is afraid to get the vaccination from different disease. Vanessa, Gregg, final thoughts for this conversation in order to close this conversation, but with the promise that we going to connect very soon.
But just to thank Vanessa for inviting me and for all of you for listening in.
Yeah, thank you, Gregg, again for your time. Send please my regards to the friends at the Yale Law School. Thank you to all who have joined us. You have our emails. Don't be afraid to reach out, and please stay healthy and stay safe.
Thank you. Let's remember that this will be available in our YouTube channel. Please reach out and see you soon. Thank you.
Thank you.
Bye. Gracias, Vanessa.
A la orden.